forms around the venous valves. If you look at the picture on the right hand side, we see the two veins there, the one wherein the flow is very normal and all the RBCs are spread out with uniform flow. Whereas in a patient with deep venous thrombosis, the flow of the blood is impeded due to blood clots and the adhesion of the RBC over the clot. And this is how the normal blood vessel and the DVT blood vessel veins will look like schematically. These are some of the clinical presentations of deep venous thrombosis. The picture on the left hand side shows deep venous thrombosis of the left leg with pigmentary changes around the calf muscle and swelling of the calf. Whereas the picture on the right hand side shows deep venous thrombosis of the right lower limb with a uniform enlargement of the right lower limb, and notice that the unilateral nature of the edema is striking in this particular picture. Please carefully observe the picture on the left hand side, which shows swelling of the calf muscle of the left lower limb, and this is due to the deep venous thrombosis of the left lower limb involving the vessels of the calf area. Whereas the picture on the right hand side here also an affliction of the right lower limb with a uniform swelling and redness and pigmentary changes of the right lower limb. This is characteristic of deep venous thrombosis. Look at the picture on the left hand side. It shows a classical venous ulcer on the malleolar area. Chronic deep venous thrombosis will lead to pigmentary changes and ulcerations of the lower limb, particularly around the lower part of the leg. This is a chronic venous ulcer due to DVT. The picture on the right hand side is about air travel. Prolonged air travel is a strong risk factor for DVT because during air travel for long distances one has to sit for long hours without much of limb movement, and that is what produces or predisposes to deep venous thrombosis. So it's important for all the people who go on long air travel to at least get up once in 15 minutes or half an hour, stretch their limbs or walk down the corridor there within the aircraft itself for about 2 or 3 minutes and then come back and take the seat. That way they can reduce the chances of deep venous thrombosis. Doctors, remember that not every sore leg is DVT. In an endemic country like ours, we see lymphatic filariasis very commonly. The filarial lymphangitis, either acute lymphangitis or acute lymphangitis superimposed on a chronic lymphedema, is very often seen by us, and this produces unilateral limb swelling with tenderness and pain. But this is not deep venous thrombosis. All of us can easily recognize this particular condition because it's associated with high fever, chills, there will be regional retinitis, history of residence in endemic area, and of course the classical features of filariasis of the lower limb will be present. And we cannot mistake this for a deep venous thrombosis. Certainly in some early cases of lymphedema, there could be a doubt, in which case we may have to investigate both for filariasis as well as for deep venous thrombosis. Remember, not every case of sore leg is due to DVT. Look at this picture. It is a patient of necrotizing fasciitis. There will be intense pain of the area affected. There is inflammation along with necrosis. Patient may be in shock. Usual tests for DVT are negative in this particular patient. This is not a case of DVT but a case of necrotizing fasciitis. Not every case of sore leg is DVT. Look at this picture. It is a patient of compartment syndrome wherein the anterior compartment of the leg is affected. Typically, compartment syndrome of the leg occurs in the anterior leg. There will be history of trauma The limb in that particular part will be tender and hard. Passive stretch sign is positive. The usual tests of DVT, of course, are negative in this patient. Once again, this is another patient who is not DVT but has a painful sore leg. Look at the localized abscess on the leg. And here we have localized inflammation, tenderness, redness, fluxing and swelling. And there is no indication for doing any tests of DVT in such a patient. This is a patient of abscess of the leg. This is another patient of an ulcer on the toe. Look here, severe calf pain in this patient, ischemic ulcer on the toe, history of smoking or diabetes, no swelling or tenderness and a presence of intermittent claudication. Skin changes and the 5 P's, that is the pain, the pallor, the pulselessness, the paresthesias and paralysis are the signs of PAD. This is a PAD ulcer on the toes. The diagnosis and treatment of deep venous thrombosis has undergone a paradigm shift and change. Around 10 to 15 years ago, a scenario like this, if a patient is admitted with calf muscle tenderness and swelling and a diagnosis of DVT is entertained, doctor would say like this, Julie, you may have blood clot in your legs. I am going to get a special X-ray called venogram for you. If the test is positive, you will be in bed for 10 days. We will give you blood thinning medicines. So in those days, the diagnosis of DVT is dependent upon venography, injecting a dye into the veins and taking pictures and keeping the patient in the bed for 10 to 15 days to treat the DVT. But now, see the next slide, what happens. The new reality now, the change in the diagnosis and treatment. Here the doctor, he exclaims, but if the well score is 2 or more and the D-dimer is positive, I don't think one negative ultrasound is adequate to rule out DVT. Repeat the ultrasound after a week and then review the patient. That means today's diagnosis of DVT is not based on venogram. It is based on clinical suspicion plus doing a D-dimer test and the compression ultrasound. What are these? How to do those tests, how to interpret will be the next part of our lecture. The patient is called for repeat ultrasound after a week and now the doctor exclaims, oh, repeat ultrasound is positive. Okay, don't admit him in bed. Put him on dalteparin and let's go on to the next case. Today, the treatment of DVT is simplified. It is not immobilizing the patient or making the patient bedridden for 10 days to 2 weeks like earlier days. It is to treat the patient on an outpatient basis using low molecular weight heparins like dalteparin. And the patient will be sent home once the diagnosis of DVT is confirmed and will be asked to come for follow-up. Every patient of suspected DVT must be scored using this Wells score to assess the Pretest probability of DVT. What are the clinical characteristics? What is the scoring? Let us see. The clinical characteristics are active cancer in the patient, or the patient is under treatment for cancer, either palliative or curative. We have to assign 1 point. Paralysis, paresis of the limbs or plaster immobilization of the limb, 1 point. If the patient is bedridden or kept as inpatient for more than 3 days, or patient has undergone major surgery in the past 12 weeks, then again 1 point is assigned. If there is localized tenderness along the course of the deep veins of the lower limb, 1 point is assigned. Swelling of the entire limb also is given 1 point. Calf muscle swelling of 3 centimeters or more compared to the normal side. Here the measurement is taken 10 centimeters below the tibial tuberosity for comparison, and such a patient who has got calf muscle swelling 3 centimeters in excess of the normal side is given 1 point. Pitting edema confined to the symptomatic leg, not bilateral pitting edema, unilateral pitting edema of the symptomatic leg, 1 point is given. Collateral superficial veins, if they are present, they are given 0.1. Remember, varicose veins are not collateral veins. Varicose veins are long-standing varicosities. Collaterals are those that have developed because of the DVT. Previously diagnosed DVT, the patient has got history of DVT, again 1 point is added. Likewise, for each of these clinical findings, we go on giving 1 point and total of those points. If an alternative diagnosis is at least as likely as DVT, then 2 points are reduced from the total score we obtain. That's how a patient is scored. Then how to interpret the score of pretest probability given by Wells here? That will be the next slide. What is this D-dimer? Whenever there is a clot that is formed inside the vein due to DVT, that clot gets dissolved by the action of plasmin, and then the clot is degraded by the plasmin, and the degradation products of fibrin are detectable in the blood, and one such product is the D-dimer. What is the utility of D-dimer? D-dimer test is a highly sensitive test, 99% sensitive. That means if the D-dimer is negative, we can safely exclude the disease. But unfortunately, this is not a very specific test. There could be a lot of false positives with this. Poor specificity cannot make it a confirmatory test. False positivities occur due to trauma, surgery, hemorrhage or cancer. Usually D-dimer is done using the ELISA method, and this ELISA D-dimer is widely available. Rapid diagnostic test using the D-dimer antigen is going to be available very soon, just like your pregnancy test, HIV card test or the hepatitis B card test. The only problem with D-dimer test is the D-dimer is negative, we are in a soundtrack and we can exclude the disease. If it is positive, it drives us crazy, and we have to do several tests like an compression ultrasound, a repeat ultrasound, and probably some more work upon the patient. D-dimer, the critical concentration of D-dimer to be called positive is more than 500 nanograms per ml. If we have a patient who is suspected to have DVT, we have to follow this algorithm. Determination of the pretest probability of